Good morning, everybody. It's 7 o'clock, and thank you to those who've joined us so far. We've had an exciting few lectures. This morning will be Antoinette Rue is going to talk about anticoagulants in ECMO and also monitoring of the ECMO patients in the ICU. It's quite an important part of being able to do ECMO in ECMO centres. Antoinette, are you there?
Yes, I'm here.
Thank you very much again for assisting with the series. You can go ahead.
Okay, cool. Good morning, everyone. Nice to see you all again. Last week we did the cannulation part, and the week before that we actually touched on what is ECMO and what it's all about. And today we're going to go through anticoagulation in ECMO and monitoring of the ECMO patient in the ICU. So first of all, let me just go on with my thingy. Why isn't it moving? Let me just see. Oh.
And now press enter.
Enter. Okay.
All right. Otherwise, stop sharing and then reshare.
Okay, cool. Share screen. Okay, here we go.
Antoinette,
ja.
kyk links onder. As jy op jou skerm beweeg, kyk links onder is daar pyltjies. Gebruik hulle.
Ek het niks sulke pyltjies. Wag, ek kyk. Okay, here we go. Zoom share.
Doesn't matter how many times you test it. When you want to do it, it won't work.
Oh, nee. My patient, the extrinsic pathway of coagulation and the intrinsic pathway. And with what do we anticoagulate the ECMO patient? All about ACTs and the alternatives for heparin if you can't use heparin anymore. So first of all, this is the extrinsic pathway of coagulation. So you'll have a cannula in situ, which is this plastic part or material surface. Then the blood comes running past it, and the surface area is a foreign body to the patient. And then he makes fibrin strands to actually hook onto the plastic. And then as the fibrin strands hook onto the plastic, the platelets comes running past and they hook onto the fibrin, and then you get a white clot. And then you get your red blood cells that comes in, and then you have a full-blown clot, as you can see on the very far right. So this is what happens when you cut yourself, and when blood gets exposed to oxygen on the outside, it makes a clot, and this is basically what happens. So we need to intervene in this clotting process in order for our blood to be more thin and not to clot the membrane. At the bottom there you can see a picture, and this is what a clot would look like in the membrane if you would have one in there. So we're going to carry on. So why do we use heparin? Heparin is a cheap or a cost-effective or inexpensive anticoagulative medication. So it inhibits platelet and coagulation cascade activation with the ECMO circuit. So it's also unfractionated. So we can't use anything that's fractionated because we want to mix it and we want to be able to monitor it. So if you can mix it in a bag, then you can actually easily titrate it and give it according to what your needs would be. It is reversible, although we don't reverse any of the heparin on ECMO ever, because you're going to clot your membrane and then you won't have a effective ECMO run in the end. It's easily to monitor it with your ACT or your PTT. It's got a short half-life, which means it will work out on its own. It drops on its own if you don't give it anymore. So we use heparin as the most basic one anticoagulate the patients on ECMO. So we actually anticoagulate the circuit purely because we want to maintain the surface area of the membrane for the fusion to take place. If it's clotted there, then the fusion can't take place into the membrane with regards to the oxygen that we add and the CO2 that we want to remove. Yes. So if you look at the intrinsic pathway of heparin in anticoagulation, heparin goes into the blood and then it needs to take something out of your clotting cascade. So what heparin takes out of the clotting cascade would be your prothrombin or your thrombin in the end, and that makes it more fluid-like, so it doesn't clot that easily. But now, if you keep on giving heparin, then you're going to reduce all your fibrin in the blood. So you need to balance your fibrin or your thrombin in the blood, and the only way that you can do that is by replacing it with antithrombin 3 or 9 that we find in FFP. So remember to balance your thrombin levels. Otherwise, your patient's going to get into a bleeding situation or can go into a DIC. So we need to balance that. And the way that you're going to notice this is when you brush your patient's teeth, they're going to have bloody gums, or they're going to bleed out of the access sites, or they're going to have bloodiness when you suction them in their lungs. So be sure to replace your thrombin that you're removing. Otherwise, your patient will go into a bleeding disorder. So the management of heparin, normally when we go onto ECMO, we give around about anything between 3,000 and 5,000 units straight away into the patient's bloodstream via the central venous catheter. And so that we are ready to go onto ECMO and we don't clot the membrane. So we will mix a separate bag of heparin. We normally use 5,000 units of heparin in a 50 ml bag of saline that we give through a line via the central venous cannula so that we can keep the anticoagulation going. So it's necessary for you to change the bag or the syringe that you've mixed the heparin in every 6 hours. And it doesn't help that you make them all your bags in the beginning of the day. You have to change it every 6 hours because the heparin clings to the plastic of the bag, and then your heparin solution becomes very unstable, and then your anticoagulation is not going to be properly managed. So measuring the heparin effect. So heparin infusion is regulated to keep the ACT and or the PTT within the ECMO limits. So in the beginning, when we started with this ECMO, we actually, and if you look at the literature, they used to give or keep the heparin ACT at about 180 to 220. But as we went along, we actually reduced it dramatically. So if you're on VV ECMO, we suggest that you maintain your ACTs between 140 and 160, and for VV ECMO, and for VA ECMO, we would go from 160 to 180. But now with the COVID patients, it seems like we need a higher ACT, so we manage it around about 200 in some patients, but it will all depend on your patient's needs and what you are busy doing. If your ECMO is running fast, meaning your blood flow is around about more than 3 liters, then you can get away with a less amount of heparin going into the patient because the blood is not stagnant and it's moving very fast, and clotting of the blood will be less if you've got a fast running ECMO. So you'll have to look at your patient to see what his needs are, and if you go into a bleeding situation, be sure that you adjust your heparin. And also we need to give FFPs to actually replace the antithrombin 3 and 9, as I've said. Otherwise, you are definitely going to go into a bleeding situation. So you will decide on the amount on your ACT levels according to your patients, and there I've said it again. So the PTTs we will keep between 55 and 75 for ECMO purposes. And at the bottom there you can see your ACT machine and the tubes. So first of all, you need to have one of these, or both of them, the tubes and the ACT machine, readily available for each ECMO situation, because this is how we're going to manage our heparin levels. So it's important that you have this in your setup where you are working. And if you are going to transport a patient in the emergency situation, be sure that you do an ACT before you leave and when you get to the other side again. So it's also important that you have the tubes. There's also different ACT machines on the market. Some use like a little glass plate that uses less blood, but this is the one that you most frequently would see in most of the hospitals that you are going to be working in. So how do we do an ACT, and what does ACT mean? ACT stands for activated clotting time, and it's measured in seconds. So that's actually the amount of seconds that it takes for the blood to clot after it left the body. So when you are going to do an ACT, you need your machine ready, and it must be next to the patient's bed. It mustn't be in another room or far away. Then you must have one ACT blood sampling tube ready, and the tube looks like the one at the bottom of the screen. And you will see that there's a clay substance in the bottom of this tube, and there's also a marking on the tube. So you're going to draw 5 mL of blood from the arterial line, which you are going to discard, and then you're going to draw another 2 mL of blood from the arterial line. As you are drawing this 2 mL of blood, someone or you must start the ACT machine to start counting it, because this is when your blood is now leaving the body. Then you're going to fill your ACT blood sampling tube to the black line. As in the previous slide, you will see at the bottom, there's like a little black line at the bottom of that tube. And in the tube, there's a clay substance, and that's your activator. So as soon as the blood is in the tube, you need to mix the clay activator with the blood. And there's also a lead metal piece that you have to shake from the one side to the other side to mix this clay with the blood. So mix it 10 times, and then you're going to put this tube into your ACT machine, and then the machine is going to ask you for a patient number or your passcode or whatever you have to put in there. You're going to put that in. If you don't know the code, put zeros, press enter, and then the seconds will be counted down, and you will be able to see the seconds that's counting. So the ACT is the number that you will see when the counting has stopped. So initially when we go on to ECMO, after you've given that 5,000 units, when you are busy cannulating the patient, you will see that your first ACT might be somewhere around 300 seconds that it takes for the blood to clot. So give it time, do your ACTs every hour afterwards, because the half-life is so short, it will drop down to about 100 or so, or into the 160s in the next hour or two. And as soon as it's in the limit that you wanted, say for instance, you wanted between 180 to 200, and you're now at 180, then you start your heparin infusion. And the heparin infusion will be titrated according to the patient's needs. So also do your ACTs for the next 6 hours, I suggest every hour, so that you can see where you are at, and go up with 2 or down with 2 or whatever the case might be, because you don't need a lot of it to actually go into the patient per minute or per hour. So titrate it according to that. And be sure that you know how this works. So the longer it takes for the blood to clot, so if your seconds are more than 300, it means you're giving too much heparin. So you need to reduce the heparin if you are on your heparin infusion already. If you're below the 140 or 160, whatever you want to be at the bottom limit, then remember you have to increase your heparin. Don't think because the seconds are high that you have to go up with your heparin and vice versa, because that can be kind of bad, and you're going to mismanage your heparin infusion, and you're going to have not a very reliable anticoagulation going. So that is how you do an ACT. And be sure that everyone does it in the same fashion, because if one is going to do it this way and the other one's going to do it that way, then you're not going to manage your heparin properly. And then it's actually bad for the patient, because he can either go into a bleeding situation or the membrane can clot. And then it was a very expensive exercise, and yeah, we're going to waste the membrane. So we also have heparin alternatives. So when your patient develop heat or have a brain hemorrhage in the ECMO run, then we have to change our heparin to something else, which is not so taxing on the platelets or the red blood cells. And remember that we cause a lot of hemolysis with the heparin, and our pump speed and the revolutions that the pump is running at is also causing a lot of hemolysis. So by doing good, we're also doing bad to maintain this membrane. So it's important that you manage this well. Okay, so the heat is heparin-induced thrombocytopenia, and we can create it by giving too much heparin and not replacing the fibrin or the thrombin with your FFPs. So be sure that you manage that well. Heat can also occur, say for instance, your patient had a bypass previously and now is on ECMO, and he had a lot of heparin in theater to go onto the bypass machine. They do reverse it, but sometimes the patients become resistant to the heparin, and you will see it because you're going to increase your heparin infusion, and you're not going to be able to maintain your ACTs where you want it, and you have to go up and up and up, and it means there's a resistance towards the heparin. So you need to change to something else. So the alternatives that we have is Angiomax and Agatroban, and that's what you'll read about in the literature. I've never seen it in South Africa, but it is the ones that they talk about. The others that they are trying out is a Rixtra, and for a Rixtra, you're going to do an anti-factor 10 Rixtra level. So when you do the levels, you're going to have a loading dose on there, and you're also going to have a maintenance dose or therapeutic dose. So keep it within the therapeutic dose, and this is a fractionated anticoagulative. So be sure that you manage that well. That also works well. And then what we've used before is citrates. Now citrates come in a poly bag, like you'll see at the top of that picture here. You'll get it from the pharmacy. And citrates actually is the same thing that you have in your blood products to keep it from clotting. So in your red blood cells or your packed cells, there's citrate in there, and that prevents the citrates will prevent your blood from clotting from the blood bank. So if you get what you have to use there, then just remember it like that. So citrates will be given pre-membrane by the perfusionist or the intensivist, and it's going to be like an infusion through an infusion pump, and you can read all about that. Now, what does citrates do in your intrinsic clotting cascade? So it needs to take something out to make your blood more fluid-like. So the citrate will remove the polymer, which is calcium. So if it removes the calcium, you've got an anticoagulative state in the blood. And remember, with taking your calcium out, your calcium levels are going to drop. So you need to balance that out. Like with the heparin, you have to balance your fibrin levels, your thrombin. In citrates, we need to balance the calcium levels. So it's important to replace the calcium and keep it within the normal limits. And you're going to give calcium chloride or calcium gluconate, IVI. And if your patient's calcium levels drop too low, your patient's going to go into a tetanus state. So just be on the lookout for that and prevent that. So that's the alternatives for heparin. And yes, okay. So the second part of today's stuff is monitoring the patient on ECMO in the ICU setup. So we're going to go, how do you manage your ECMO device, and how do you manage your patient? So it's important not to treat the machine. you should actually treat your patient. So everything that is still viable for treating a normal ICU patient will be necessary for you to manage your ECMO patient as well. So the ECMO device is only there to actually give oxygen and reduce the CO2 in the patient. The rest of the things that happen in the patient is going to be like it is supposed to happen. So please note that every patient is different, and you still need to stick to the basics, because the basics not going to change. So you have to keep your eyes on everything around this patient. Then what can go wrong on ECMO? We can discuss that. And maintaining the patient on ECMO according to all the systems in your body. And I think afterwards you'll have a clear understanding of how you need to manage these patients. So first of all, monitoring of the ECMO device in the ICU. So you're going to do your ECMO observations hourly, and there's a few terms that you have to be sure of, that you have to be on the lookout for. So first of all, the blood flow. You're going to observe your blood flow in the patients, and that is actually partial cardiac output. So in the previous parts that we've handled, you have to work out or know your patient's cardiac output. So if you have calculated your patient's cardiac output, then on VV ECMO, we're going to take care of 60 to 70% of that total blood flow or cardiac output of the patient. And on VA ECMO, we're only going to take care of the 80%, because we still have a functioning heart and we still have functioning lungs. It's not like on bypass where we stop the heart and we take care of the full cardiac output. So ECMO is partial cardiac output that we have to take care of. And this is where we will start off initially when we go onto ECMO. As we go along, we'll reduce the blood flows and the gas supply, and that's how we're going to wean from the ECMO. So revolutions per minute is another thing that you'll record. That's also called the RPMs, and this is maintained by your centrifugal pump. So if you look at the picture at the side, we will drain. Where's my bulky now? Okay, so we will always pull the blood out from the inferior vena cava, or in this case, they're using the internal jugular going into the superior vena cava, and this is central cannulation. So we'll pull the blood from the patient, and the blood will be pulled out of the patient via centrifugal pump here. And as we pull it out, we get a negative pressure. So the negative pressure will be from the patient to the pump, and that's going to be your P venous, or your venous pressure. So the one pulling the blood out of the patient, the unoxygenated blood, will be your venous pressure, and it will always be a negative pressure. Then we get to the pump. As soon as the blood reaches the pump, it becomes a positive pressure after the pump. So between the pump and the membrane, we get the P internal, and that will also be your highest pressure. So this pressure needs to be high enough to push the blood through the membrane and allow for oxygen to come in and CO2 to be removed. And then the oxygenated blood will be pushed back to the patient. And then the pressure after the membrane will be your P arterial, or your arterial pressure going back to the patient. This is going to be slightly lower than your P internal. And then we've got another pressure that we measure, and that's called delta P. So the delta P is your P internal, which is the pressure between the pump and the membrane, minus, or you subtract the arterial pressure, and then you get your delta P. So if you look at the picture, between the pump and the membrane is your P internal. This is your highest pressure to push the blood through the membrane. And then after the oxygenator of the membrane, we've got your P arterial. So if you subtract the P arterial from the P internal, you get the pressure across the membrane. So that's your transmembrane pressure. And this will give you an indication of how well your membrane is functioning. If that pressure increases, your delta P, so for instance, your baseline was around about 20, and now it slowly moves up to about 40, then you must suspect that your membrane is clotting. So you have to have a clear eye on your membrane, check it with a torch, and see that there is no clotting taking place in there. The only reason that your membrane can clot is because you're not managing your heparin properly. So check your ACTs, see if everyone's doing the ACTs in the right fashion. Is your heparin bags changed every 6 hours? See if you can't adjust anything there. There are ways to anticoagulate the membrane if it starts clotting, but we're not going to go into that now, but I can send you some information if you need that. Then the SVO2 is another term that you'll see in ECMO. SVO2 is your central venous oxygenation, and it's measured at the right atrium where the least oxygenated blood returns back to the right side of the heart. This is very, very important because this will tell you how much oxygenation has taken place from the right side to the left side. And then we're also going to manage our HPs and hematocrits. We need an HP of about 10 or above, not below, because remember your HPs are carrying around your oxygen and we need red blood cells to carry them around. Then the temperature is also one of the things that you'll see on your ECMO device. So the temperature that you'll read there is the temperature before the membrane and the temperature after the membrane. So it's not really the core temperature of the patient. So if that's very low, then you can actually see or suspect that your patient's core temperature is even lower. So it's important that you correlate between the machine and the patient's temperature to know where you are at. Okay, and temperature is very important in ECMO, especially in VV ECMO, because we need to maintain it between 36 and 37. Otherwise, your heart rate's going to slow down. You're going to have your metabolic rate's going to slow down. Your heart's going to pump slower. And if it stops on VV ECMO, then ECMO won't save the patient in the end. Okay. Then things that can go wrong on ECMO. So first of all, there can be a bubble in the circuit. And how do you think air can get into the circuit? Do you think it could be pre-membrane? We are now busy with the P venous, that's pulling the blood out of the patient and sucking the blood out of the patient? Or do you think it's after the membrane where we are pushing the blood back into the patient? So remember, after the membrane, if you look at this picture of mine here, this is after the membrane. So on the blue side, the blue line will pull the blood out of the patient. It's a sucking pressure, gets to the back of the membrane, the pump will push it through the membrane, and then after the membrane or post-membrane, we'll push it back into the patient. So if you think about it nicely, if we push it back to the patient, anywhere that we're going to open on this side of the membrane, which is post-membrane, the blood will be spurting out. So there won't be any space for air to come in there because it's a pushing pressure. The air bubbles can only come into the patient at the pre-membrane side where we are sucking the blood out of the patient. So when we go on to ECMO initially, all kinds of things where air bubbles can come in, we will sort out. So for instance, your access site was too big and there's air sucking in there, or you've maybe nicked one of the plastic lines and there's a hole in there, so there can come air in there. That will be sorted out as soon as the patient is on ECMO in the cannulation situation. When your patient gets to the ICU, all of that will be sorted out already, when we after we've connected the circuit. So now when the patient is in the ICU, the only other way that air can come into the system is via your central venous catheter. So be sure that when your lines are running freely without a pump, you are gonna get air into your system if you don't close them off nicely. So keep your eyes on blood and FFPs running freely. As soon as you see that the chamber is getting empty, make sure that you close off that line. If you have air in your lines, don't flush it into the system because it's definitely going to be picked up by my ECMO membrane and circuit. And then you're going to have air in your membrane, and the air can actually overshoot into the patient. So if you've got air in your system, or your circuit in your machine indicates that you've got an air bubble, you have to clamp your circuit as close to the cannulas as you can. And those clamps at the top there is your best friends when you're busy with the ECMO patient. You need to have clamps visible. You need to know where your clamps are, because they are going to save the day. So as soon as you see an air bubble, or the machine notifies you that there's air in the circuit, you need to clamp the arterial line first, and then the venous one. And then you have to see how you're going to take it off out of the circuit. So in the hands-on situations, we'll show you how to remove air from the circuit. It's very dangerous if you don't remove it and you just shoot it through, because you can cause an air embolism to go to the head predominantly, and that's going to cause a lot of trouble in any case. And then if air gets into the circuit, it also causes clotting. So set your air bubble alarm or the intervention on the ECMO device, so that you can take out the air before it gets to the patient. And that's actually the only way that air can actually come into the system from our side. So be sure that you don't flush any air via your arterial line or from your central venous cannula into the patient, because we're definitely going to get it into the circuit. Okay. So then clotting in the membrane. This means your heparin is not managed well. Or sometimes if we give cryo, it can also clot up the membrane. So we don't really give cryo. We'll give FFPs and platelets and red blood cells. You're going to check your delta P, which is your cross-membrane pressure. So some of the devices will work it out for you, and others you'll have to work out your delta P. And be sure that your delta P won't shoot up immediately. So it will happen over time. So you still have time to check your clotting in the membrane. We can manage that by either increasing your heparin levels, or we have a few other things that we can do to actually reduce clots in the membrane to prevent the membrane from clotting completely. So if you're in charge for the day or you shift leading, keep your eye on the delta P, so that if you see that it's creeping up, so that you can make manage it early enough so that you don't have clotting of your membrane. And then if it's definitely clotted, you need to do a circuit change out and plan it well, so you've got another machine to set up another membrane, and so that your team can get together, so the doctor can actually do the change out in a controlled fashion. It's not an emergency thing, it happens over time. So plan well, and I always say prevention is better than cure, so we don't really want to throw away a membrane that's costing a lot of money, so we'll rather try and maintain it. Then accidental decannulation. Now this is a very serious situation. As nice as ECMO is, it's still a very fast moving circuit. So we have got a blood flow of about 3 to 4 liters per minute. So the cannula that will most likely pull out will be your arterial cannula or your return cannula, because it's a shorter cannula, it's a thinner cannula, it's normally in the neck. And accidental decannulation most often happens when your patient's almost ready to come off ECMO, and they actually look normal, because now they're extubated, they are sitting in the chairs, they're eating normally, they're talking, they're actually fine, and you think that you can leave them alone, but you still can't leave them alone, because there's still 3 to 4 liters running through the circuit per minute. So if they move around, or say for instance your sutures became a little bit loose over time, then this thing can easily pull out. So what are you going to do? So you have to have your clamps readily available. Make sure that no one leaves the patient alone for a specific period of time, especially when they're awake and moving around. And then you're first going to clamp your red line or your arterial return line. You're going to clamp your blue line or your venous line that's pulling the blood out of the patient. And you're going to go to the front of the machine, and where your RPMs are, you're going to reduce your RPMs to 0 as quick as you can. You're going to put pressure on the area that the line has pulled out, and you're not going to run away. Okay, so when this happens, you call for help and you start doing your things. So you're going to clamp the red line, then the blue line. You're going to reduce the RPMs to 0, because as long as the RPMs is around about 3,000 or 6,000 or whatever the case might be, it all depends on the machine that you're using, you are still pulling blood out of the patient. And remember, you only have 2 minutes to save the day. So clamp, reduce your RPMs, put pressure on the site, call for help, and please don't run away, because you'll come back and all the patient's cardiac output will be on the floor and on the walls and everywhere else. So this is a very sad situation that does happen, and it can be prevented if you are with your patient the whole time and keep your eye on him. The other thing is have blood readily available so that you can fill the patient up as soon as you can. Otherwise, these patients are not going to make it. And then you've got a perfectly well patient that would have been decannulated in a proper fashion the next day, or could have come off ECMO, and now you've got nothing. So be sure that you keep your eye on the patients when they are close to coming off, because these accidents actually happen when they are very awake. Okay. Then patient monitoring on the ECMO. So first of all, we're going to go through the neurovascular system. Please do your Glasgow Coma scale every hour or how often you do it. Check the pupil reaction. If there was air in the circuit, you can have a variance in pupil reaction. You can have unequal pupils. You can have dilated pupils. And then this was also a good patient to come off ECMO, but now because we've had air in the circuit, we don't have a patient anymore. So as soon as you see that there's any changes there, report it, and then we can react according to that. Then you have to manage your sweep gas properly with regards to your neurovascular system, because if you increase or decrease with more than 0.5 or a liter per hour, you cause constriction and vasodilatation in the brain, and that can also cause your patient to have a bad GCS. Then sedation. So sedation is initially just to get the patient cannulated, get the patient relaxed, get oxygen into the patient, and then we need to wake the patients up. It's sometimes difficult. We don't want you really to sedate the patients for too long, because then we lose a lot of intercostal muscles, and they're not able to breathe properly. So we want them to be sedated for a little while, and then you need to reduce the sedation and wake them up. So the waking up process can also be a difficult one, because they move around, they get anxious, especially if they didn't know what they were in for and they were ventilated and then went into ECMO and they don't understand what's going on around them. And everyone tells them how dangerous this thing is and they don't want to move, and it becomes a terrible situation. So sedation, you'll decide on what you want to use. So normally they use Dormicum. Propofol actually clots the membrane, so we don't really use propofol, although I see now later days they use propofol, so it all depends on what your situation is. Then muscle relaxation agents like Nimbix and so on. We use Nimbix initially or Esmeron, but we also need to steer clear from them as soon as our patients have stabilized, because they also cause the intercostal muscles not to be able to work afterwards, and then we've got problems with breathing and getting them back to where they are supposed to be. So we don't really relax them for so long. So and then we will carry on with Presidex. You can give a high amount of Presidex to relax your patients or to sedate them nicely and keep them kind of so that they can work with you instead of work against the machine and the ventilator. And then in some situations, we've got people who will rather come off ECMO first and then off ventilation. If that is the case, then it's easier to work with the sedation. If you opt for the option to first come off ventilation and then ECMO, then it's a kind of a tricky one. So there's a fine balance between over-sedation and sedating them just so that they can actually manage themselves. Then you must also provide an emotionally safe environment for the patient. So if you are going to tell them how dangerous all of this are, they're not going to cooperate, they're going to be scared. Don't leave them alone because they really are scared. So calm them down as you go along. And yes, just keep them emotionally safe because they are really feeling out of their space in this situation. And please don't leave the patient unattended. If you need to go for tea or something, get someone else to sit there while you're not there so that they stay calm and they are not alone. Okay, so neurovascular, that's all about there. Then if we look at the patient monitoring on ECMO regarding the cardiovascular system, you still need to monitor your patient hemodynamically like you would normally do. So if your patient's got a tachycardia, make sure that he's not dry or needs some volume, or if he's anxious, if he's got a cardiac output problem, give him some inotropes to reverse that. If he's got a temperature, address that. So on VV ECMO, we keep the temperatures between 36 and 37. It's very important, like I've said just now. So if they're going to have a temperature of about 35, you're definitely going to see a bradycardia on your monitor, and that means your patient's getting too cold. So if you don't have a heater unit, like with most of our cases, then you can use a bear hugger or put blankets on the patient. Because if your cardiac output slows down on VV ECMO and you're only supporting the lungs and not the circulation, the heart's going to stop and you're not going to be able to revive the patient if the patient is too cold. You can give atropine as much as you want to. You can resuscitate the patient, but if the patient is cold, you're not going to get him back. You have to know what to do in case the ECMO device fails. So if your patient's on VV ECMO and your ECMO device fail, you have to increase your gas flow either on the ventilator or ambubag the patient. And then on VA ECMO, it's blood flow dependent. So you're going to increase your cardiac output by either increasing your inotropes or giving some volume to get your cardiac output back. Check if your patient's bleeding. Maybe he needs to give some blood and assist him in that way. Check your blood results. So it's important that your platelets is in the normal values. If you see that your platelets are dropping, please give them some platelets because otherwise your patient's also going to go into a bleeding situation. So you're going to have Malena stools, you're going to have bleeding in the lungs, you're going to have gastric bleeds. They're going to bleed out of every access site. If your albumin is low, also replace that so that you can get oncotic pressure in your vascular system so that you can actually pull the blood, the fluid out of the third space into your vessels, and so that you can have more blood flow going on there and not a lot of fluid in the third space. FFPs is also advised, especially when you're on heparin, so that you can replace the fibrin. That also helps with your oncotic pressure. And if you need to give any boluses on ECMO, we advise that you give blood products instead of clear fluids because that will also increase your third space fluid. Then you also have to have blood and FFPs readily available or on standby. And we need to keep the HP above 10. Be sure that you know what the hematocrit is so that you can actually, that will also give you an indication of if your patient is dry or if you need to reduce some volume. Okay, so that's cardiovascular. Then monitoring the patient on the respiratory or ventilation side. We normally, as soon as we go into ECMO, we wean the ventilation to protective lung ventilation as soon as possible. So protective lung ventilation or resting ventilation settings would be your FiO2 must come down to 40 because we're managing the oxygenation from the ECMO side. You have to keep your tidal volumes between 6 and 7 liters per kilogram. You have to come down with your pressures below 25 at least. And you can have a PEEP of about 10 to 12 on ECMO. So if you are ventilating the patient on ECMO, the ventilator will only be there for compliance. So be sure that you choose the right mode of ventilation. So OPRV and SIMV pressure would be the ones that we will use. The reason for that is on APRV, which is pressure-assisted ventilation, we will push in a high pressure and we will reduce the pressure to 0 and there will be no intrinsic PEEP. So that actually just gives your alveoli time to stretch and recoil to its normal size again and maintain your tidal volumes. So keep your eyes on the tidal volumes. If you see it shrinking slowly, say for instance, you started off with 300 and now it's somewhere between 70 and 60 over a day or so, it means your compliance is not there anymore. And then your patient's actually developing fibrotic lung disease. So as good as all of this is, we can also cause a lot of damage. So make sure that you maintain your patient's alveoli for compliance and stretchability. So yeah, and if you've got fibrotic lungs on ECMO, it means you're not going to get the patient off ECMO. So then the patient becomes dependent on the ECMO, and then this was also not a patient with a good outcome in the end. So yeah, ABGs, you need to know the normal values and carry on like you normally do with your hemodynamic monitoring. So the PO2s must be between 80 and 100. 100's a little bit high, I suppose, 80 and 90 maybe. Then your CO2s must be between 35 and 45. Your bicarb 22 to 27. Your pH between 7.35 and 7.45. Your base excess between -2 and +2. And check your AA-DPO2, which is your AA gradient. So that's your transmembrane pressure between the inside of the alveoli towards the capillary. If that increases dramatically, it means you've got a lot of third space fluid around the alveoli and you need to get rid of that. So, or you need to increase your PEEP. So we maintain a PEEP of about 10 to 12 on ECMO. So that will also help you a little bit there. Then, and do everything that you would normally have done with regards to your ABGs. Make sure that you are not in an acidic situation. So the 5 things on the ABGs that's going to tell you about the acidity of the patient would be your pH, your bicarb, your CO2, your base excess, and your lactate. If those are out of sync or not balanced, then it means the acidity levels in your patient's too high, and if your patient's too acidic, he can't oxygenate properly. So, and you're going to have cell death on tissue level. So we don't want that. We want the best. We want to maintain the best we can with regards to cell function in all ways. So make sure that you address whatever is going wrong in your ABGs. Then if you're on ECMO, we do not manage the CO2 with the rate or the tidal volumes or the pressures on the ventilator anymore. We manage the CO2 with a sweep gas. So it's important that you understand the sweep gas. So at the bottom here, you can see the picture of the secret blender. That's what we normally use on ECMO, but you can also only use a flow meter. The secret blender is divided into 2 parts. So this one part here on the right side is going to take care of your fraction of oxygen. So it works from 21.21 to a liter. So this is your fractionated oxygen. So the flow meter on the side here is actually taking care of your CO2. So the one part takes care of the oxygen and the other part takes care of the CO2. So if we go into ECMO, we normally go on on ECMO with a sweep gas of 1:1. So 1:1 would be, it would be your gas flow will be equal to your blood flow. So if you worked out that your patient's cardiac output is 5, then we normally start on 5 on the sweep gas. Oh, sorry. So you will see here on the, where's my bulky? So if you started on 5 here, and now you do your CO2 and you see, oh, on your blood gas is now something like 50, then you will have to go up with 1 liter or 0.5 on your sweep gas to actually reduce the CO2 level in the bloodstream. If your CO2s are lower than 35, you will decrease by 0.5 or a liter. So you will go down with your sweep gas. So that's how you're going to manage your CO2 on the ECMO device. So you also have to prevent oxygen toxicity. So when are we at oxygen toxic sites? That is when our PO2s are above 100. So reduce your oxygen levels so that your PO2s stick below 100, because as soon as it goes above 100, you have all kinds of different things. And like with babies, you can also have blindness in the patients. We had the patient who became blind because of too much oxygen. And that's not a nice thing to have when it was a successful ECMO run, and now you've got a patient that doesn't see. So you use the ECMO FiO2 on the blood gas machine. You're doing a blood gas. So instead of taking the ventilator FiO2, you're going to use your ECMO FiO2, and if you're only using a flow meter, then it means it's always 100% FiO2. If you're using a gas blender, then you can fractionate it. So say for instance, your FiO2 is 120, then you can come down from a liter to 90%. And this 90 would be the one that you're going to use on the blood gas machine. So you use the ECMO concentration of oxygen to put into the blood gas machine so that you have adequate blood gas. Then the best place for you to do an arterial gas is on the right radial artery. So if you need to do a blood gas, you will do it on the right side, because that's where the blood returns back to the heart and where you've used up most of your oxygen. And that would be the most true and accurate gas that you can take on ECMO. Then you also have to suction your patient 4 to 6 hourly to make sure that they don't have any secretions and that your oxygenation is taking place as it's supposed to. Okay. All right. Then patient monitoring on ECMO. On the gastrointestinal side, so you need to give high protein feeds. So we normally give the patients TPN initially when they go into ECMO, and then we will start giving them nasogastric feeds. It's important that you feed them properly. The high proteins will also pull your third space fluid intravascular and also help with that. And be cautious of the right sedation. So if you are giving patients morphine, remember that morphine slows the gut. So your patients is most likely not to be able to absorb if you give them a lot of morphine. So just keep your eye on that. And they can also develop ileosis or gastric bleeding, which you need to treat as soon as possible. And then TPN and enteral fees, like I've said. Okay, so on ECMO, they use a lot of energy, and we need to restore their tissues as good as we can so that they have the energy to breathe when they need it. Okay, so patient monitoring on ECMO. On the renal side, intake and output must be equal or in an equal or a negative balance. And as soon as your patient goes onto ECMO, we start reducing their volume. So you'll put them on Lasix to get them as dry as you can so that you can make the alveoli function properly. And if you've got blood in the urine, either you've got your heparin needs to be adjusted, or your P-ven is more, or your venous pressure is more negative than 100, and you need to reduce the flow. So as soon as you go into ECMO, remember that your initial cardiac output will drop. And about a liter weighs about 1 kilogram. So if you work out the cardiac output, you will see that the demand is not as much as it was initially when you went onto ECMO, because you're reducing the volume and you're also reducing the weight. So keep that in mind. If your lactate is elevated, we normally don't put patients on ECMO that has had a lactate of more than 2 or 3 for about a week or 2 or maybe more. If it's acute, then we can reduce it nicely on the ECMO, but otherwise it's permanent because the acidic state was there for too long and you've got a lot of tissue death. And if your lactate is high, please opt for dialysis, because these patients lie still and they've got a lot of muscle breakdown, and they can go into rhabdomyolysis, and that causes acute tubular necrosis. And we need to get rid of these muscle cells that's blocking the tubuli in the renal area. So put them on dialysis, get rid of all the extra big molecules, and protect the kidneys, because we already have 2 organs that's kind of failing on ECMO, and we don't want more organ failure. Then also remember that if you give them a lot of Lasix, you can cause a diuresis, and that can also lead to a drop in the cardiac output, and you need to adjust what they need. You also need to adjust the partial cardiac output that you are busy with. Okay. Just basic patient care. You have to turn the patients to prevent bed sores. You must check the pedal pulses for perfusion and capillary filling time. Check the access sites for bleeding, especially in the groin area. You can easily have a hematoma in the groin area, so check that. And if it's necessary, change the sites and put pressure on there. On VA ECMO, you must have a distal perfusion cannula to save a limb. Otherwise, you're definitely going to have loss of your perfusion on that side. Site care, as per hospital protocol, prevent catheter-related infections. And we normally don't have a lot of catheter-related infections due to the cannulas, and we don't change them often. So they will be there from the beginning to the end without being changed. Suture check, especially when your patient's on ECMO for a while and he's starting to move and he's not ventilated anymore. Make sure that your sutures are nice and intact and nice and tight, otherwise the cannula will slip out. Then you need a crepe bandage around the head to secure the cannulas that's placed in the neck area. And if you need to restrain the patients to prevent accidental decannulation, then you have to do that. You can put the patients in semi-fowler position to prevent FAP. You must mobilize the patients as soon as possible and wake them up so that they can start using the intercostal muscles again. And always involve and help the physio when they come along. Don't leave them to do their own thing, because this is it is a very daunting thing as well as a very good thing. But if the cannula slips out while the physio is busy there, then it's also not a good thing. And then with mouth care, just observe the mucous membrane. If it's bloody, then you have to reduce your heparin or give FFPs to actually turn that around. Okay, and this is just something to look at. What do I do for a living? I breathe in and out, and I hope you enjoyed it. And is there any questions?
Hi, Antoinette. Thank you very much for an excellent lecture. Are there any questions for Antoinette? I think you can unmute. Fawn, will you try and unmute? Just type if you can't.
Yes, here I am.
You can. Okay, I just wanted to check that it was available. Are there any questions? Just want to have a look on the chat. There's nothing on the chat either. Right, okay, so then the series will be available on the Netcare YouTube. If you just type in Netcare YouTube, you'll be able to see all the lectures, and this one should be uploaded probably by tomorrow morning. Antoinette, have you got anything final?
No, that's all. Thank you so much.
Okay, then what are we doing next Monday?
Scenarios, and let me just see here. I have to check it now. I'm going to tell you now.
Yeah, you're correct. We're probably doing some scenarios, and then you're going to also repeat the cannulation side of things next week. Is that correct?
Yeah, I'll do that.
Okay, perfect.
Yeah.
All right, then if there are no questions from anybody, there were 55 of you on today. You are real stalwarts in ensuring that you stay with the series. I hope you're learning something. And then we're going to be having a practical session, as you can see on the program. And I'm just wondering now with the COVID increase, whether we need to look at whether that practical session can be broken up into a morning and an afternoon. So we'll chat next week about those who want to join the practical session. And then we also just want to welcome Dr. Nathi Mdlala, who's joined us for his series as well. So thank you very much, everybody. We hope it is valuable, and we'll see you next Monday, 7 o'clock. Bye.
Bye-bye. Thank you.
Everyone, bye.